Can you give me one paper? Just one single, thank you very much. Give it to me, and if it is possible, one pencil and a red colored pen, if you have it. Super. Using this paper, let's try to modulate our region, which is called subinguinal region. Yeah, let's understand the localization of the structures inside of this region. Okay. 1 pencil also. Thank you very much. Much more better to see once to understand instead to 100 times just to say about something. So we'll try now to show all these structural units, which is together called the inguinal channel, femoral channel, inguinal and femoral hernias, and to show the attention of each one to another's. Let's open it for you to make at the same time visualization. Approximately that is what I need to show for you. Now look everybody to me. This is left subinguinal space. This blue margin, which I draw here, we can duplicate it in this paper also. This blue margin, which is looked towards of you, it is the inguinal ligament. My inguinal ligament pass from lateral to the medial, from up to down. I show for you all these inguinal ligament from anterior iliac spine up to the gimbernac ligament, the place where it is joined with the pubic bone, yeah? To make the legs much more stronger and to prevent dislocation of these legs in the region of the pubic bone. Do you have any other color, for example, green? Is it green? Super. Thank you very much. If you will attract now your attention into green structure, that will be our pelvic bones. Immediately here, guys, we will mention two bones. The medial one, it will be the superior branch of your pubic bone, and the more lateral and upper portion, it will be the iliac bone, region of the greater wing of the iliac bone. Approximately in the border between medial and middle third, we will have eminentia iliopectinea, junction between your pubic bone and between your iliac bone. Again, guys, look everybody to me. What we have here, Posteriorly, we have the bones. Anteriorly, we have inguinal ligament. By the way, also inguinal ligament will have a little bit superior position. Bones, little bit inferior position. That's why then we describe these borders. We say anteriorly, superiorly, we have inguinal ligament. Posteriorly and inferiorly, we have the pelvic bones. Yeah. Now, generally, you can find that this region, which is located behind of your inguinal ligament and between your pubic bones, has approximately a horizontal direction. Little bit oblique, descending from anterior to posterior, but mainly it is horizontally directed. Yeah? Do you agree with me? If I will turn it towards of you, you will see that it is divided by proper fascia. This proper fascia, guys, cover this whole muscle which is located, this red serrated quadrangular portion, it is the iliopsoas muscle which is descended by inner segment iliac bone, greater wing of the iliac bone, and which is formed by the junction of the psoas muscle of iliacus muscle and Holly's muscle located in one common sheet, which forms by the fascia pelvica, pelvic fascia. It is continuation of our endo-abdominal fascia. I told you last time that inside of pelvis, it's split it into parietal, into the visceral. Immediately you see now parietal layer of the pelvic fascia, which is covered wall with the muscles, yeah, which can attract your attention, guys. To tell the truth, I make here one. And that mistake is connected with the size of our muscle. Muscle is much more bigger because muscle occupy the lateral 2/3 of the space, not the half as I draw. But now I improve it, and you can see I provided it until the vascular wall, proximally. Yes. And this blue structure, which is cover the muscle, and in the same time, as you can see in this model, from backside it is become to the bones. From in front it is fused with the inguinal ligament. You can ask me why it come to the bones. Idea is simple, guys. It should cover the part of this bone without the muscle. Because previously it covered the muscle, which is located in the surface of iliac bone. But this muscle doesn't become to the pubic bone. It is nude here, it's not covered. And this fascia come to this pubic bone, it is superior branch, cover this pubic bone, and fused portionally with periosteum of this pubic bone, and together they forms the fascia pectinea. Why pectinea? Because here we have eminentia iliopectinea. Pectineus, it is another name of the pubic bone. Because it has crest shape, upper margin, so we call it pectinea. It is covered, this bone. And finally, guys, unfortunately, my model is not correct, because the more we come to the medially, the more narrow will become to this space. And finally, we must have here the junction between bones and inguinal ligament by formation of the lacunar ligament, otherwise Gimbernat ligament. I cannot modulate it so correctly. That's why I just will connect it, these two margins to each other, means the posterior and anterior one. And it will be the model of our Gimbernat ligament. Idea is understandable for you. Very well. Again, I make one big mistake. Then you try to do something very quick. Of course, you make the mistakes. What about my next mistake? Two rings medially to this facial structure. By the way, this facial structure we call arcus iliopectineus. And this arcus iliopectineus, this horizontally posited region, split it into lacuna musculorum and lacuna vasolorum. Laterally to it we have muscular space, medially we have vascular space. Very well. Now, if you will look to this lacuna musculorum, again one mistake. You will see one muscle and two black structure. Black structure, it is the nerves. One nerve is located laterally to the muscle, approximately this margin, guys, margin number 1. It is anterior superior iliac spine, the place of origin of your inguinal ligament. Again, upwards they join to each other, like downwards. I cannot modulate it, that's why I just show by the numbering here, yeah? In the level of anterior superior iliac spine, laterally to musculus iliopsoas, we have the nerve. Nervus cutaneus femoralis lateralis. In the future, you will see that it continues, it passes through the lacuna musculorum, then just behind of your inguinal ligament, it is continuous into anterior femoral region. Now imagine that from frontal plane below the inguinal ligament, it is from the horizontal plane, it is come to the frontal plane. It is continuous by the lateral surface of your thigh region and make innervation. We call it skin nerve, yeah? It's originated from lumbar plex, it is passed through the lacuna musculorum, come to your thigh region, and innervated lateral surface of your second nerve, which you see here, it is much more bigger, and it's located between arcus iliopectineus and between your iliopsoas muscles. This is biggest branch of your lumbar plexus. We call it nervus femoralis. By the way, guys, this division of femoral nerve from femoral vessels will be keep also and in femoral region. Inside of upper third of femoral region, in medial interfacial space, which is called here femoral triangle. Little after I will show. By the way, in this picture you can see this is triangular shaped space, which is completely covered by the proper fascia. I told you last time that in the region with single cone, proper fascia forms interfacial space. Exactly this interfacial we call the medial interfacial space. And these three structures, look at this, blue ring, red ring, and black ring, descended again below the inguinal ligament. Let's say they come from deep to superficial. They pass approximately artery pass in the level of the midpoint of your inguinal ligament. Vein is located more medially, nerve is located more laterally. And they descended to down into the femoral region. Here in the femoral region, this proper fascia is very, this intermuscular septum medial is very wide. It is very wide. Then you draw it in cross section. It takes such kind of the form. Then you look into it from in frontal section. It has triangular shaped form. Now my right hand, which is the right side to this triangle, called musculus sartorius. My left hand, which is located in left side, it's called adductor longus. Adductor longus. This is adduction. That is abduction. And both these muscles, can you come to me, please? Can you put your hands like this? Can you put your hands in front of my hands? This fascia. Proper fascia located between my hands.
Yes.
And proper fascia cover here two muscles. No, keep it up. Two muscles. Because between my two muscles, we have hair muscles. And under her hands, we have two other muscles. Her hands now in front of my hands, between my hands, it is proper fascia. But behind will be two other hands. It is two muscles. One of these muscles, thank you very much, you can see it. I show for you before, it is iliopsoas. Again, it is passed behind of your ligament, and it forms, guys, floor of this triangle, but in lateral side. Second muscle, it's originated in thigh region mainly, and this is located much more medially. We call it musculus pectineus. Now, my left hand is pectineus. My right hand is iliopsoas. You can see the groove between them. My both hands covered by proper fascia, which goes to deep and fuse with my femoral bone. It is medial lip of the femoral bone. You remember from Trochanter, Meyer, and Miner, two ellipses descending, to downwards. One is medial, second is lateral. It is fused with the medial one. That's why we call it septum intermuscularis medialis. That's why remember, please, medial serratus line, we call it linea aspera medialis. And lateral one, which is, posterior one, which is located there. That's why it is fused with linea aspera medialis of the femoral bone. That's why keep it in your mind. This proper fascia forms the intermuscular septa, which is covered two muscles, which is formed floor for the femoral, and two muscles located much more from sides and forms borders for these triangles. Now imagine that behind of my inguinal ligament, my trips descended immediately into this triangle. By the way, my second finger called the femoral vein, my third finger called the femoral artery, my fourth finger called the femoral nerve. And in this triangle also between vessels and nerve, we will have the connective tissue septa. We call it septa of Cloget. And it's also separated vessels and nerve from each other. In the future, you will see that nerve will be inside of triangle. As you can see in this picture, it gives a lot of branches. Portionally muscular, portionally sensory. And the longest branch, which after will continue with the vessels, we call nervus saphenus. Your nervus saphenus will reach up to your foot region. So remember, please, that is the longest branch of the nervus femoralis. But below this triangle, femoral nerve is absent. By the way, after you will see that in middle term, this triangle will be collapsed. And instead of triangle, we will describe anterior femoral groove. It is very narrow, fissura shape. If upwards between these two layers of intermuscular septa there are wide space, in middle third it's collapsed. In the lower third, instead of groove, you will see channel. You will see channel which we call adductus channel. Three names it has: adductus channel, Hunter's channel, because hunters old times have professional disease. You know why? Then they put the gun in front of shoulder, not behind of the shoulder. This tail of the gun during the walking usually make the traumatization of the inferior medial surface of your thigh region, place of location of this channel, and it can give the chronic inflammation of this channel. That's like it gives the professional disease for the hunters. And it has one more name, very interesting, which is femoropopliteal channel. Look, adductus channel because it forms by adductor muscles. Hunter's channel because it can make professional disease. And femoropopliteal channel because that is channel which is connected your thigh region with the posterior knee region. And finally, due this channel, your femoral vessels will go into the knee region, into the posterior knee region, and will be renamed and called popliteal vessels. Let's say popliteal vessels, that is continuation of your femoral vessels. Just up to the channel or inside of the channel, we call it femoral. In the below the border between your knee, and by the way, border is easy. You find upper margin of your patella, you provide it the circular line. Below this line we have knee region, above this line we have thigh region. You understand me? Yes. That's why so long I describe this for you, to explain for you the passage of these three, let's say behind of inguinal ligament, they descended to down. I means blue ring, red ring, and black ring, not this next black structure, which is located medially. Do you see? I draw one more ring. Now it is black color, and it's located immediately laterally to your Gimbernut ligament. Gimbernut ligament, which is connected inguinal ligament with your pubic bone. Super. If it is understandable, don't forget that here between vessels there are one more nerve. I don't draw it, but it is the femoral branch of the genitofemoral nerve.
Yes.
Again, together with this red and blue, it is descending into your thigh region, and it also supplies the medial of femoral region. Three nerves you will see. Nervus ilioinguinalis, iliohypogastrica, ramus femoralis, nervi genitofemoralis. Absolutely differently, they reach this region. Absolutely differently. You can see that femoral branch of the genitofemoral come from lacuna vasorum, behind of your inguinal ligament. Tell me please, how reach ilioinguinal nerve to this region? You see? You see what is happened when you don't study the previous words. Easily, guys, easily. Can I take your exercise book? Easily, if I will turn now tube and will put this tube just above of my inguinal ligament, it will form the inguinal channel. And ilioinguinalis nerve, as you remember, located inside of this channel for both genders. But for males and for females, for both. And for both genders, guys, it will continue to down. It will come to the external ears, and terminal branches will be turned into the femoral region. You see, through the inguinal channel, by superficial ring of inguinal channel. You remember, for the males, it connected the channel with the scrotum. For the females, it is finished bluntly in the level of the pubic bones. But anyhow, terminal branch come to down, reach the medial surface, and work here. What about iliohypogastrica? Iliohypogastrica innervated the fatty tissue of your hypochondric region. You remember about it. Doesn't go to the inguinal channel. It doesn't innervate it. Terminal branch just through the fatty tissue in front of your inguinal ligament. If this nerve, which is between the hasp of the ligament, and reach to our final destination. This through the fatty tissue, yeah? This is fatty tissue of your belly. Through the fatty tissue of your belly, immediately it is descending from up to down, reach the anterior medial surface and work here. Make the sensory innervation. That's why, guys, upper medial surface is so sensitive. By the way, a lot of the mechanoreceptors, nociceptors, 3 nerves make the innervation of this region. 3. You will see in the lower compartments, picture will be changed. Yeah, one nerve will be in middle, one nerve will be in lower. In middle will be the skin branch of nervus obturatorius. In lower will be nervus saphenus, which I showed for you just minutes before. Just minutes before. The longest branch of your nervus femoralis. Keep it in your mind, remember about it, and let's come again to our model. You can ask me, you can say, sir, what is it, this black hole? Because this is not the tube like artery and vein. That is hole. If it is hole, let's cut it. Let's cut it, and let's modulate it here aperture. This is really aperture, guys. This is aperture. And that is aperture which is located medial to the vein and lateral to the lacunar ligament. Or the borders of this aperture. Everything is here, guys. Everything. In front, inguinal ligament, behind the pectineal fascia. Medially, Gilbert ligament, laterally, it is the femoral ligament. By the way, guys, these femoral vessels also have facial coating. Fascia coating them also. They are located inside of the capsule. Is it that they are not just inside of the space. Fascia cover them and form the sheet for them. Okay, now what is it? This aperture, guys, we call deep ring of femoral channel. And now you can see that these deep, all borders you remember, yeah, I told you now. This deep ring of femoral channel has horizontal localizations. Horizontal. Now, again, come to me. Again, let's understand, guys, now let's understand positions. It's very important, guys, not just only to study, but to imagine all these information which we now describe together. You must imagine. Now look, this is my space. You can see that my inguinal ligament is oblique. It passes from up to down, from lateral to the medial. Again, I cannot connect these two margins to each other in this paper, but in reality they join to each other, yeah? And this green margin, as you remember, it is the bones. In reality, they direct it a little bit downwards, because the inguinal ligament located a little bit upwards. Can you open your fingers and put it above? No. Why are you doing it in such a strange way? Above this paper. You know what she modulated by her fingers? Endo-abdominal fascia. Do you remember I told you that this muscle is covered by endo? We call this fascia pelvic fascia, yeah? And as you remember, this pelvic fascia has the parietal, has this visceral layer. Again, can you put your fingers? We cannot now modulate it, but in reality, her hand, can you little bit, no, in oblique, in such a way. Her hand, in reality, passes from up to down. Because her hand comes from abdominal region into the pelvic region. Sliding through the walls, it goes from up to down. Do you agree with me? This part of her head, which is located above this region. By the way, approximately here we will have the arcuate line. Let's say up to my hand we have abdomen, below my hand we have pelvis. Her hand is continuous to down. From up it shall come to down, cover this downward stretch. Now look, part of her hand which is located above of my, we call fascia endo-abdominalis or transverse fascia. Call it how you want. Give me your pen. And little bit open your fingers. Part of this hand, which is above this subinguinal space, perforated. You know why her hand is? Because through this deep ring, hold it with your finger, lymphatic vessels pass from lower extremity to the abdominal region. And they should perforate this fascia to be drained into the iliac groove of the lymphatic nodes. That's why her hand is perforated. And her hand from upwards cover this deep ring of the femoral channel. Remember, please, part of this hand, which is covered this ring from upwards, thank you very much, sit down, we call fascia cribrosa interna. Cribrosa, it means perforated. It is the deep perforated fascia, which is covered this deep ring from upwards. In the future, it will be very important. Come on. Just hold your hand. Now look, guys. Little bit. No. Turn it to my side. This is fascia. It is perforated. I am very sorry. What is above this fascia? Of course, peritoneum. This parietal peritoneum. What does it mean, hernia? It is protrusion of organs through the weak places covered by non-damaged parietal layer of the peritoneum. Do you agree with me or not? Let's imagine that our friend from upwards by the fist push my hand to down. His hand will be guts, intestinal content. They want to find a place with low pressure. Is it weak place or no? Yes, of course. I prove you 2 minutes before that this is weak place because we don't have anything between gymbernated fascia and between vessels. Medially to it we have the ligament, laterally to it we have vessels. Here we don't have anything. That's again your hand. Dear, sorry. Again, if I need to find weak place, one of these weak places will, by the way, my hand, it is inguinal ligament. I can give the herniation above this ligament or below this ligament. If I will be herniated above this ligament, I will form inguinal hernia. If I will be herniated below this ligament, I will give the femoral hernia. Why I have these both opportunities? Because and above inguinal ligament, we have weak place, by the way, much more weaker than this narrow, small compartment. But also below it, I have the weak place. That's why I can be herniated in two directions, or immediately from back to in front. In that case, I will come to the fossa inguinalis, medialis, or lateralis. We'll push them and will form or direct or indirect hernia. And I know that the targeted population, it is the males. Or, God knows why, I will decide it instead of it, go to down. Go to down, pass through this deep ring, and instead of inguinal hernia, I will form femoral hernia. Thank you very much. Now look, guys, but why I make such kind of strange decision? Why instead to go by the short way from deep to inside, come to fossa inguinalis lateralis or fossa inguinalis medialis, forms here the oblique hernia or forms here the direct hernia. Why I decided? Why I decided to go down? More interesting question. For whom I decided to go down?
Females.
Not just females. Females after usually 45, 50, look, with many pregnancies and deliveries, many means 3 and more. What is happening with this aperture? It's enlarged. You can ask me why it is enlarged. Answer is more than simple. The more pregnancies will have the female, the more dilated will be inguinal ligament.
Yes.
The more enlarged will be the pelvis. Then the pelvis become too larger. Look again. Then the pelvis become too larger. Your inguinal ligament goes much more horizontally upwards. The more inguinal, the more pelvis become to the narrow, the more vertical position.
Yes.
I'm very sorry. That's why we see the mechanism, how this ligament is delayed from the bones. Then the ligament delayed from the bones, size of this aperture is
Increase.
I think it's so simple. And the more dilatation of the inguinal ligament from the bones I will have, the more will be the chance for formation of this hernia. Friends, do you understand me? Let's say normally nobody from the presented persons doesn't have any femoral channel, any femoral hernia. But you have this ring. Me, you, everybody, we have this ring. But this ring is not so much weak to give formation of the hernia because it has the normal size. Normally, guys, the diameter of this ring approximately it is from 0.5 up to 0.8 centimeters. That's not enough to give the hernia. Minimum, we must have dilatation up to 1.5, 2 centimeters to give the formation of the hernia here. For example, in this picture, you can see a biomechanism of formation of this hernia. Intestine from upwards compress the peritoneum, consequently compress the fascia cribrosa interna, inclinate it into this small ring. But what after? What after? To say what after, guys, I must cut one more aperture. I must cut one more aperture. But now, aperture which I cut it is much more bigger, first of all, comparable with the previous one. And what is important, by the way, same you can see here in the picture. And what, guys, frontal location. If the previous one located horizontally, this one located frontally. immediately below your inguinal ligament. Immediately below your inguinal ligament. Look in the picture. Recognize this ring. Here the name of this structure. Proper fascia. This is proper fascia. That is removed. You see proper fascia. Of course, in region of thigh, we call it femoral fascia. As always in extremity, it has two layers, superficial and deep. And of course, this is superficial layer because deep one will form the intermuscular septus, which we described before. Now, virtually, she will hold her hand in front of mine. Hold your hand like this, horizontal. Is it resemble to our cross-sectional pictures which we usually draw for extremity? From the ring, which is superficial layer of the proper fascia, from the deep layer, intermuscular septa is originated, and junction between my hands, it is the bone. Please come to the bone and fuse with the bone. I lose my paper.
Backside chair.
That's what do you see here, guys? You see here the evolutional, developmental defect of the proper fascia, which is called hiatus saphenous. This is deep ring of ear channel.
Yes.
There is superficial ring. No any communication between them until I will not insert my finger from one ring and will not push to outside through another ring. My finger will be femoral. Junction between these two rings we will call femoral channel. Little after I will discuss its formation. Just now remember, I forms by mechanical pressure communication between upper and between lower rings. Immediately in the time of this herniation, femoral channel is formed. Before we didn't have it. Before we have both these rings without communication to each other. Unusual situation, because before we described the normal channel with the normal rings, like the inguinal one, which exists. But now we have the channel which normally doesn't exist, but which has its rings. Now let's imagine that this is one ring window, that is another ring door, but we don't have any empty space between them. For example, we have just a stone, big stone, between them. Now what is necessary to form the perforate this stone?
Yes.
If something will press this stone, stone is hard to imagine, some, elastic structure, and will perforate it, now between the door and between the window, communication will be happening. This communication we will call channel. So normally we have two rings, we don't have communication between these rings, we don't have channel between them. Idea is understandable. By the way, to tell the truth, this ring is not empty also. Superficial layer of proper fascia, which is disappear and gives formation of hiatus saphenous, in reality also have the form of the cribriform fascia. Now it is covered this ring from in front. That's of course we call it external cribriform fascia. That's a deep ring from above covered by internal cribriform fascia. Superficial ring from in front covered by external. Now look, guys. If I will try to pass from up to down and come outside from this superficial ring, how many layers will cover my sac? My sac is parietal peritoneum. First of all, it will be covered by internal cribriform fascia. Then I will have loose connective tissue, which is located in this deep ring. By the way, except loose connective tissue, deep ring contains deep lymphatics of your inguinal region. And the biggest one we call the Rosenmüller-Piragov's lymphatic node. That's it. Partly these structures will come. Then we will have external cribriform fascia, which is covering. Then we will have only subcutaneous fat tissue together with the skin. Yeah. So from skin we will have skin, fat, superficial fascia, external cribriform fascia, fat, internal cribriform. Do you think that such kind of hernia, so many coverages will be big? Of course not. In majority of the cases, compression from in front will be so big that just no any chance to give the big protrusion. Which case I will give the big protrusion? If I will make so big power that I will rupture these two cribriform fascias. Only single way to form here the big protrusion. Then I say here what I mean below the inguinal ligament. This is the best differential method between your inguinal hernias and between your femoral hernias. Open your eyes and look this picture. That is inguinal ligament.
Yes.
And you see that protrusion located not above, but it's located below inguinal ligament. Single conclusion, that is the femoral hernia. Otherwise, we will have this protrusion above the ligament. It's not hard to put your fingers, for example, and palpate this inguinal ligament. It's not hard. Inguinal ligament, except the very big peoples. In all other cases, inguinal ligament is easily palpable. More of this, approximately by position of fold. Again, fold can have some dislocated position, especially for big persons by gravity forces. It can be descended down. It's much more better to use like the landmark, the ligament, not the fold. Yeah, but the very slim person, let's say you can see fold, you understand that that is exactly level of the inguinal ligament, and you see that the protrusion is located below it. But now instead of this slim person, let's imagine big person. Let's understand that you can see now the size of this protrusion near 1-2 centimeters. Sometimes it is smaller. I imagine, I'm very sorry, 150 kilogram patient. In your opinion, this protrusion will be visible?
No.
In majority cases, it will be even unpalpable. Unfortunately, guys, age doesn't make us more slim and beautiful. Fortunately, you understand that if there are many pregnancies, if there are under 15, I don't say always. In majority of the cases, it will not be 45 or 50 or 60 kilogram person, and it will be not so easy to see these hernia. It will not be easy even to palpate this hernia. By the way, majority of the females, even after palpation, they will think it is the inflammation of the lymphatic node, which is common in inguinal region, yeah? Until pain. But you know that reducible hernia is not painful. Pain is started, then it comes to irreducible or touch wood, strangulate. Yes. That's why, guys, then you ask the stupid questions like which hernia is better, big and small. Of course, no one hernia is not good. Much more better to not have hernia at all. But big hernia show itself. It's impossible to have, for example, indirect oblique hernia, which can be in the size of the big ball, and to not recognize it. Here it is more than possible to waste the time until the problem will be grow up to unreducible or touch wood strangulated, and only after this to go to the hospital. Because we don't go to hospital, then we don't have problems, guys. It's not the walking place. That is make the diagnosis of the problem not so simple. That can waste time, that can form the health and life-saving problem, because any strangulated hernia can be mortal. After strangulation, we can achieve the necrotization, perforation, formation of the peritonitis. Keep it in your mind. Remember about it. Now look to me. What is this blue trunk which I provide hiatus saphenous and insert inside of it? I don't know, I might have here picture or no to mention it. sure that in next picture, next your lecture, I will have it. That's just 1 minute. I will open your next presentation. Oh, this one, that one, and attract your attention into this blue structure. Of course, it is vein. If it is vein, it is ascending because veins is come in lower extremity from down to up.
Upwards.
And I don't know, is it visible or no, but it is coming. It is originated in dorsal foot.
Yes.
And then it is ascending to upwards, mainly, predominantly by the medial surface. Through the leg, through the knee, to the femoral region, biggest superficial vein of the human body. Because this is subcutaneous fat tissue. Skin and fat is removed. This white structure, this superficial layer of proper tissue, and that is venous which it forms. And the vein which you see here, we call vena saphena magna. Vena saphena magna reach this hiatus saphenous and then drain inside of the femoral vein. This is femoral vein. Now this blue trunk drain in my hand inside of this hiatus saphenous. After we will speak about phlebectomies, for example, in case of the varicose disease, phlebectomy. Vena saphena magna also is removed in case of the varicose disease. Up to the level of the hiatus saphenous, we ligate it and we remove it. To prevent formation of the phlebitis, thrombophlebitis, which can be complication of the varicose disease. Let's say keep it in your mind and remember about it. Now, guys, let's start to speak about formation of the femoral channel. Now, look everybody to me. And lower margins of this hiatus saphenous is very thick. And we call upper one cornu superior horn. Lower one cornu inferior. That's a cornu superior, cornu inferior. Laterally, they connected to each other with sharp margin. It's called Marco falciformis, falx. Now look to me, guys. We have very unique situation. Look everybody to me. Cornu superior joined by the inguinal ligament. You can see that superior horn located exactly below the inguinal ligament and they fused to each other. Cornu inferior, guys, have the septus which is come to the pectineal ligament and joined to it. That's a superior horn joined with the inguinal ligament. Inferior horn have the septus connected with, because it's located in reality in the oblique way. Now what is happened? Hold your hands like this. But a little bit in front of you. Okay. This is superficial ring. That is deep ring. Look, she put the hands in frontal plane.
Yes.
I put in the horizontal plane. Now let's imagine that our friend from upwards pushed by the fist my ring, finally insert it into my ring, and come to this down located ring and want to come to outside. Tell me please, in your opinion, which ring can be dislocated due to this pressure, my ring or her ring, and why? Which ring I can dislocate it due to the pressure by up to down? Sit down.
Deep ring.
Which ring can be dislocated? Do you keep it in your mind, these two pictures?
Yes.
Yeah, deep ring, which is horizontal, superficial, which is frontal. Now, he is pressed by the fist. His fist, it is the sac with the hernia. It is pushed from up to down. Want to pass through the deep ring and come to outside. Of course, this is soft tissues, and we must to make dislocation of them, due to the pressure. Now, from these two rings, which one can be more easily dislocated, superficial or deep?
Superficial is
Dear,
down.
maybe you are right, maybe you are wrong, but I need to listen explanation. Not just this one, but some explanation.
Our creepy pressure is coming from like up to down. It's covering from downside and again coming up. So this.
Anyhow, it
ring
is
will be-
applying both rings. It doesn't apply only in the deep rings there. Finally, it should reach the level of the superficial ring, and finally, it must compress the superficial one also.
Due to the pressure, this ring can like go down.
That is impossible, my dear friend. That is totally impossible. You know why? Take this paper and say why it is impossible.
The pressure is coming from outside.
Why you have so weak logic? According to this paper, why dislocation of deep ring is impossible?
Because ligament is connecting here is deep impossible.
Huh?
Inguinal ligament like a touch with easy.
Dear friends, your eyes is open, you look to the model, and you don't recognize what the cause why the deep ring cannot be disconnected? Huh?
Inguinal ligament is connected.
What?
Superficial.
You answered in my problem. Fanta, I say why deep ring is not disconnected, you say soup. Soup, it is in Russia, it means something which we eat. What do you mean? And in English also it is soup. Why? It means you should give me explanation, guys. Awful. Awful. I waste approximately 1 hour to have this result. No any idea? 3 minutes for you, everybody. Look to this model and tell me, please, why the deep ring cannot be dislocated due to the pressure. You think that small structure cannot be dislocated?
Inguinal ligament से connection है ना.
Vice versa, the smaller will be structure, more will be pressure, which is applied in each millimeter of it. This is physical rule there. The more surface, the less pressure. The less surface, the more pressure. Do you study in the school? So why you say such kinds of thing? What is more easy to do? Perforation of soft tissue by sharp knife or by blunt? Why? It's because surface is smaller, that's why pressure will be higher, not vice versa. No any ideas? Give me return me my paper. Dear, this is scientific work, not the answer in my question. It's so simple, guys. I think that you need to have the first or second school children's level to answer in the question why deep ring cannot be dislocated.
Superficial is just by the proper fish.
And what?
But deep ring, it's ligament attached to the
And
ligament.
that is the problem, yeah? The deep ring is ligamental problem, yeah? Awful, friend. Deep ring partly is bony structure. From backwards, it is the fascia pectinea, which is covered the pubic bone. How I can dislocate the pubic bone? And how I can dislocate it fascia, which is fused with the periosteum of it? How is it possible? That is more than stupid. How the ring, which is portionally presented by the bone, can be easily dislocated? Now use your brain. More of this from medial side, it is very short Gimbernet ligament, which is joined to. Is it easy to dislocate it 1 millimeter structural unit? Is it possible to dislocate it, the bone? That is awful, friends. That's why what will be happen? Look everybody to me. Due to the pressure which he now modulated virtually by his hand, step by step, superficial ring will go far from the deep one. And it will give this tension of connections from upwards. How did it? I don't know. Man, you come to me. Oh my God, that's awful. Hold your fingers like this. And that is my fingers. Now I push. No, who will come? You, come on. Hurry up. can you insert your fist through my ring and push this one? Now what is happened? Our rings go far from each other, but we have junctions. Thank you very much. You can see it in your place. His upper margin joined by my anterior margin. His lower margin joined with my posterior margin. Now, then he starts to go far from me. First of all, I will have upper junction, dislocation, then lower. Then these two structures disconnected to each other, guys. Primary, I will achieve the difference of his fingers, because his fingers is thin. What is my fingers? Inguinal ligament, very thick. What is his fingers? Ornus superior, superficial layer of the proper fissure. That's in the disconnection, connection. Wall of inguinal channel will be formed by superficial layer of proper fissure, because he will be dilatated primary, not me. I am thicker. Then two structures is joined to each other, and you try to disconnect them. You primary will differentiate the weaker structure, the thinner and more elastic structure. In our junction, weak, thin, and elastic is his fingers, not my fingers. Is it understandable for you or not? Now then, this junction with facet pectinea will be dilated. Of course, facet pectinea cannot be dislocated, it fused with the bone. But the septas, which is joined them to each other, of course, from deep layer of the proper fissure, because under the superficial layer, we have deep layer. That's why we will have dilatation of deep layer of proper fissure. What does it form? See. My anterior hand, I modulated now the left one, yeah? Left one. Anteriorly, I have superficial layer of the proper fissure. Here there are deep ring, which is horizontal. Here there are superficial which is vertical. Yeah? That's why they dilatated from each other due to the deformation of superficial layer of the proper fissure. And I formed the anterior wall of the femoral channel by superficial layer of proper fissure. Friends, no any teacher in the world doesn't explain in such a way. If after this you don't understand, I'm sorry, I don't know what to do. Just you can just see, because that is awful. That's why again, two rings is set on each other. In this upper junction, weaker is superficial layer of proper fissure. That's why then they dilatated this elastic structure is tense, and it forms anterior wall. Why anterior? Because it is the most anterior.
Yes.
Then the inferior junction pair is dilatated. It forms the dilatation of the septas, which I described before, and it forms the posterior wall. Medially, they join to each other due to the Gilbert fissure. Yeah, we say medially we have Gilbert. Laterally, we will have femoral gate inside of its capsule. And this triangular shape in cross-section channel, anterior, posterior, and lateral. Medially, we don't have anything because here we have junction. This triangular shape, communication between deep ring, between superficial ring, will be called femoral channel. Friends, I don't know how to explain it more. I don't know, really. And inside of this femoral channel, we will have the sac of the hernia with the content. Do you understand it? Who have the problems? Don't worry, I will not call emergency. If you have a problem, just say me. I will explain it once again. Because if you will not understand this biomechanism, you will not be able to make any treatment and surgery. If it is understandable, 1 minute, I will close it to open the previous one's lecture. Now, how we can recognize it and how we can treat it. Of course, recognition, guys, provided in two ways. Here, we don't need any hard diagnostical investigation. First one, it is physical, some manipulations, palpation. Again, you can use, for example, the cupping sign. The more the pressure inside of the peritoneal cavity will be increased, the more protrusion I will achieve, and I will be able, for example, to palpate, especially for slim person with big protrusion, it will be not so hard. If it is complicated problem, very big problem, you are not able, make ultrasound, no any problem. By the ultrasound, you will see the sac, inside of the sac you will see content, so you will recognize everything. What is important for you to understand, is it emergency problem or not? Again, pain for you will be the best diagnostical criteria for this. Normally, our hernias is non-painful. Because normally we don't have any compression to the internal organs. Then internal organs is compressed, mechanical nociceptors irritated, it gives the pain reaction. Okay, you understand that this is hernia. Doesn't matter is it emergency or not, I must make the surgery. Look guys, it's drawn, okay. It's drawn here. By the way, according to position, the most common position, medially to the femoral vessels. Less commonly it can be in front or it can be pushed into the lateral side, but that is the most common position. Why? Because deep ring located more medially to the femoral vessels. So they keep this position, each one is called by some name, but generally remember. And look to me, guys, two main accesses. One access above inguinal ligament, second access below inguinal ligament. Above and below. We call it supra and infra. By the way, both methods is useful, but one is more complicated than another. Now let's imagine that I make the inferior access. Parallel to inguinal ligament, below it, I make below, approximately 1 centimeter below, by the way, not along of all, approximately from midpoint to down. Biggest problem for this access, it is to not damage the femoral vessels. You will work in the level of them. Of course, if you will cut the tissues layer by layer, as I teach you, you will not achieve any problem. But anyhow, you must be very, very careful. Otherwise, we can have a lot of the problem. But anyhow, let's understand what I should do. I cut the tissues, skin, subcutaneous fatty tissue, superficial fascia, then I will see this protrusion inside of the fat, external cribriform fascia, sac of the hair, internal cribriform fascia, sac of the hernia, fat between them. I layer by layer using the groove top. I cut the external fascia, I cut the fascia. Finally, I find the sac. All other steps, guys, is classical. We open the sac, we make revision of the content. If content is alive, you push it to inside. Near the neck of the sac, you ligated it to disconnect it from the peritoneal cavity. Below ligature, you apply arterial forceps, between them you cut the sac and remove it. Okay, we make step number 1 of technique, so-called herniatomy, ectomy. We remove it. Now I must make plastical reconstruction. The most simple, what can you do now, it is to distend your inguinal ligament to down, because space is formed, between your inguinal ligament, anteriorly it is inguinal ligament, posteriorly it is the pectineal ligament, and apply several sutures between anterior and posterior wall. This is inguinal ligament, this is your pectineal ligament. Distance between them, it is 2-3 millimeters or 1 centimeter. I will try to decrease this distance, applying the sutures. If I will decrease this distance, I will decrease the size of the deep ring. If I will decrease the size of the deep ring, I will make much more better protection from upwards, and it will prevent in the future descending of the content. I will make it stronger. By the way, I can apply also so-called heterogeneous method to put the method. Method is great, method is good, but it gives one complication. Which one? If I descend it inguinal ligament and push it to backside, which kind of problems I can achieve? Oh my God.
Obstruction.
Guys, my time is short, that's why I cannot wait you so long. I will increase, even after if this helps, somebody will answer, I will put the positive mark. I will increase money in my pocket. But I will increase. Okay, next my help. I will increase the size of I will increase the size of what? I don't understand.
Inguinal ligament is खाली अलग करना है क्या ना जर तिथून तुम खाली
Why?
it will go down.
I will increase the size of inguinal space, guys. Because inguinal space is formed between free margin of two muscles and the inguinal ligament. The more I descend the inguinal ligament to down, the more wider will become to this space. I will remove the femoral hernia, but I will achieve inguinal. High possibility, because I increase the size of the weak place. That's I use the mesh, but don't use the tangent methods if you go below the inguinal ligament. Much more better results you will have if you will go above the inguinal ligament. What does it mean? Classical access to the inguinal channel, which is intact. You open the inguinal channel, you cut the posterior wall of inguinal channel, which is transverse fissure, and exactly below it you see the protrusion, which has come from up to down. And below this inguinal ligament come to outside. All your next steps is same. You take this sac and push it from, you take the sac and push it from down to upwards. You mechanically change the femoral hernia to the inguinal hernia. Then you do everything same. Inside of inguinal channel, you open this sac, you make the revision, you push to inside, you ligate, you cut. But anyhow, now I must make plastical reconstruction of both spaces. I make weaker and inguinal channel, and we have the weakness of the inferior. It's so easy, guys. Again, you take the same upper located muscles and you tends to down up to pectineal ligament. If previously you remember we pushed them up to the level of inguinal ligament, well now we descended them down, and by 2-3 sutures, not exactly the muscles as you remember, upper flap of external oblique aponeurosis, behind of inguinal ligament, because pectineal fissure and aponeurosis it is same structure, it is the fissure. But then you tense the external oblique to down, muscles also go, because you remember first time you inserted needle through the 3 structures, second time you remove it only from the superior flap. Then you continue to fascia pectinea and apply the sutures into the fascia pectinea. Then you tie this knot, external oblique come to pectinea, joint with pectinea, 2 muscles behind of inguinal ligament, descending to the. This real distance is 2 centimeters, guys. It's not the half of kilometer. Who don't understand me? That's why then you need to make, guys, the tangent method. Suprainguinal one is the best. Then you need to make the mesh method, use which one you want. Lower is best. You see, guys, one for explanation, gift for you. For explanation of one simple topic, we need a huge lesson. Because that is the most easy for me to come and to start to speak, to give several topics together and to go to my work. But you will not achieve any knowledge. You should imagine, guys, not only in my subject, mainly, predominantly in the surgery, everything should be imagined understand. Let's say you must have some, we can say, virtual great imagination. Because if you will not imagine this, you will not be able to make any surgery. Questions? If no questions, homework is given for you. Study what they explain.